Good afternoon, everyone, and thank you so much for spending your lunch hour with us today for our Women's Health webinar. I'm your host, Katie Lucas. We are so excited you have chosen this platform to learn more about this condition that affects millions of women around the world. We'll start with a few housekeeping items, and then I'll introduce today's speaker. First, your participation in today's webinar is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speaker. If you wish to ask a question, please type it in the chat box at the lower part of your screen. We will address all of our questions at the end of the presentation. Our presentation today will last for approximately 30 minutes and will be presented by Dr. Alexcis Ford. Dr. Ford, thank you so much for joining us this afternoon, and I will turn it over to you to get us started.
Hi, Katie. Thank you so much, everybody, for joining us today. We're going to be talking about a subject that's very near and dear to my heart, understanding urinary incontinence. This is an extremely common issue that affects so many women, so we'll get into it soon. I just wanted to give you a little bit of information about me and my background. I originally went to medical school in Los Angeles at the Keck School of Medicine, affiliated with the University of Southern California. I then went to Boston and did my residency in obstetrics and gynecology at two hospitals, Brigham and Women's Hospital and Massachusetts General Hospital. And then I traveled down to Atlanta and did a fellowship in urogynecology, or female pelvic medicine and reconstructive surgery at Emory. And now I'm in private practice with advanced gynecology. I work at two offices, one in Alpharetta and another in Buckhead, and I operate in both places. I specialize in various different things, various different issues that are associated with the pelvic floor. Pelvic organ prolapse, urinary incontinence, which we'll talk about in depth today, overactive bladder, which we'll speak about, pelvic pain, fistulas, and of course, all types of different minimally invasive surgeries, from all vaginal surgeries to robotic and laparoscopic surgeries. So a lot of different things. But for today, we're going to talk about some of the most common types of bladder leakage, and then we'll also talk about the numerous different treatment options that exist. So first of all, what is urinary incontinence? If you look at this slide, this country alone have urinary incontinence. Bladder leakage, it's a loss of bladder control or involuntary loss of urine. There are different types of incontinence, which we'll talk about, but it's very common. 1 in 2 women have urinary incontinence. So in terms of the types, we see a lot of urge incontinence. So this is when, you might notice you put your key in the door to come home and you're already leaking, or you get that urge to go and you're already going before you've gotten to the bathroom. That's that unintended loss of urine due to an involuntary bladder contraction. Your bladder really should only be squeezing when you're on a toilet, when you're ready to urinate, not any other times. There's a completely different type of incontinence, which is also quite common, called stress incontinence or stress urinary incontinence, or SUI. It's the uncontrollable loss of urine. And the slide says during physical activity, but you'd be surprised. It's not necessarily doing jumping jacks or exercises. It can literally be getting up from a seated position. It can be laughing. It can be just rolling over in bed. What we hear typically is like a cough, laugh, sneeze kind of incontinence, but in general, it's any activity that puts pressure on the pelvic floor that causes leakage. That's stress incontinence. And of course, we see a combination of these two things, stress and urge. A lot of times we see women who have some stress incontinence first, maybe after their baby. It doesn't go away all the way, but it's manageable. But then as you get older, especially approaching menopause or even well into menopause, that urgency becomes much more pronounced and very bothersome. So certainly these things can coexist in the same patient. So when we look at the different types of incontinence, and we've already mentioned of the 1 in 2 adult women who have urinary incontinence, stress incontinence is very common. Almost 50% of women have that. Urge, about a quarter of women, and mixed incontinence, about a third of women have both. We talked about some of the basics about urgency urinary incontinence. Sometimes women come to me and they say, I feel like I'm not emptying my bladder all the way. And usually that's kind of code for this. You finished urinating, 15 minutes later, you feel like you need to pee again. It's not necessarily that there's actually an excessive amount of urine in the bladder. It's that your bladder senses that it's full when it's really not. And that's overactive bladder. Common symptoms we hear about are going to the restroom to void or to urinate more than 8 times a day is considered abnormal, or more than once a night is considered abnormal. Of course, you have to take into consideration what you're drinking. If you're downing tons and tons of water every day, that might be appropriate. But for the average person drinking an average amount of fluids in a day, more than 8 times is abnormal, and more than once a night is abnormal. And then sometimes we don't even see this frequency, we just see the urgency. So you might only be urinating 4 or 5 times a day, but when that urge hits you, you can't even walk 2 feet to the bathroom, you're already urinating. So that's still considered urgency urinary incontinence or overactive bladder. Stress incontinence, again, as I said, it's loss of urine during any sort of movement, putting pressure on the bladder or the pelvic floor. Cough, laugh, sneeze, exercise, jumping, lifting, I didn't mention, is very common. But again, even simple movements can cause this phenomenon to occur. There are different types of stress incontinence, and this gets into the weeds a little bit because clinically, it doesn't really seem that different, but it does matter in terms of how we fix them. Hypermobility is extremely, extremely common. So this is where the support structure underneath the bladder neck or the urethra, it doesn't work well. So what happens when you cough, laugh, sneeze, jump, laugh, whatever activity you're doing that causes that pressure, your bladder neck should remain fairly stable because it has good support. It's almost like a little hammock of support. When that support isn't there, the bladder neck moves excessively. That's called hypermobility. When it moves, it just doesn't function properly. You can't really keep urine inside with a hypermobile urethra. And so that pressure just gets translated down onto the urethra and leakage occurs. The other type of stress incontinence or intrinsic sphincter deficiency, or ISD, this is less common, but this is when the actual sphincter muscle that controls the bladder neck, it's too weak. So you can see in this little picture here, there's this normal where you see the bladder neck is quite tight, and then weakened where you see it's kind of wide or open. It's also called a lead pipe urethra, one that just doesn't squeeze properly. This can happen when the nerves that go to the sphincter are damaged, or even if the actual lining of the sphincter is damaged with previous surgeries or different things like that. There are quite a few risk factors for stress incontinence: age, menopause, childbirth, even just being pregnant. You don't actually have to have even delivered, but being pregnant can cause chemical reactions that cause a weakening of the support of that pelvic floor. Prior pelvic surgeries like hysterectomies, certainly being obese or overweight with a high BMI or body mass index, that can contribute to stress incontinence. Doing a lot of physical activity or heavy lifting, while this shouldn't be the only cause for stress incontinence, it can certainly exacerbate things. For example, if you're doing a lot of very heavy lifting like bodybuilding, even a lot of high intensity interval training, where there's a lot of explosive motion with very heavy weight, that can be a risk factor. Smoking, certainly, it just damages tissues. Just like, smokers might have skin that's a little bit different than non-smokers, that difference in tissue sort of translates everywhere in the body. Of course, genetics, big risk factor here. You might notice that your sister or your mother or your grandmother may have had a surgery for this, or may have had even just symptoms of this after children. That's very common. Diet can contribute somewhat to stress incontinence, but we think of this more as a structural issue. So diet is less implicated. And then, of course, injuries to the spinal cord, which can contribute to this lead pipe urethra. And of course, other medical conditions can definitely affect the way the pelvic floor functions. Diabetes is a huge one, but other systemic diseases like multiple sclerosis or other neurologic diseases can cause some of these things. And of course, mixed incontinence, we talked about it being a condition where both urge and stress incontinence coexist. And we'll talk more about the treatments, but for women with both, we do treat each one separately. So sometimes we'll do one, the most bothersome type of incontinence we'll treat first, and then address the other one later. And sometimes they interplay, and treating one can also improve the other. So speaking about treatments, this slide is a simple slide, but it's important to reinforce. You don't have to live with incontinence. I think that, previous to seeing me, a lot of my patients will say, I just thought this was normal, or, wearing a pad, I just thought that, my mother did, or my friends do. So, and I see commercials for these pads and different things like that. So I just thought that was normal, like having a period. It's not. You don't have to live with it. It's not something that needs to be, quote unquote, managed. It can be fixed. So that's my job. And it's important for us to be very clear about that. In terms of seeking treatment, what are the barriers that women have? We know that this is an embarrassing issue, and less than 50% of women even bring this up. Even if they don't think it's normal, it can be very shameful. And so hiding it, it's easy to hide a lot of times. Sometimes it's not easy, but when it is, it's on us as providers to really probe for some of these things. And I think we can do a better job of that also. Of course, in my job, this is all I do. So we very much ask these questions right away, but in a primary care setting, I think there's less of that happening. And again, being unaware that these conditions can even be treated and just thinking that it's normal, that's a big barrier as well. So in terms of urge incontinence or overactive bladder, OAB, what are the treatment options here? We always go from sort of least invasive to most invasive. So when we talk about least invasive, what are options that are not surgeries? There are first line options, which are just lifestyle changes, not a pill you have to take, just what can I do to help myself? So exercising, changing things in your diet, modifying, some of your activities, even some of your exercise regimens, that can be helpful. Losing weight can be helpful. Physical therapy, this is like if you actually see a physical therapist. There are people called pelvic floor physical therapists who we as urogynecologists rely on heavily to really help retrain the pelvic floor for our patients. So that is definitely a viable option. Pills or oral medications, that's considered second line therapy. It's still non-invasive, not surgery. There are some medicines that are available to help relax the bladder. And so we talk about those at our consultations pretty early on. And then minimally invasive surgical options, doing Botox, just like Botox for the face. It's literally the same medicine. Botox can be injected into the bladder. So we can do this awake. Also, you don't have to be put to sleep, but putting a little camera in the bladder and injecting it in the inside with Botox can be helpful. There's something called tibial nerve stimulation, or PTNS. This is, almost think about it like electroacupuncture. That is really what it is. We use a little acupuncture needle, and there's the tibial nerve. We access that. It's right behind the ankle, the inner part of the ankle. We connect that needle to a little bit of electricity. It sounds scary, but it just feels like a buzzing. But that tibial nerve, it travels up the leg and runs very close to the nerve that goes to the bladder. And so we know by activating that nerve, we can calm down the bladder. We're not totally sure actually how that works, but we know it is effective. And then there are other surgical options, something called sacral nerve stimulation, where it's almost like a pacemaker for the bladder, where the same concept as a pacemaker for the heart. It's a little battery connected to a wire, and we tunnel that wire along the nerve that goes to the bladder. And it just sends a signal to the bladder to help calm the bladder down. So there are a lot of options, and it's important to know, not everyone is right for everybody, but we can usually find something that works. In terms of stress incontinence, so this is different, as we talked about. This is more of a structural issue. So there are two different approaches. One is, how do we make it so that there's not so much of a load on the bladder, on the pelvic floor? And those are things like modifying exercise activity. So if you're, maxing out on your squatting, maybe you can do less weights. If you're doing a lot of high intensity interval training, maybe something that's a little bit of a lower intensity can help. Thinking about decreasing the load on the bladder as well. Losing weight can help, and it's not like you need to become, supermodel thin. Losing 10% of body weight has been shown to be very effective in helping the pelvic floor and reducing the amount of leakage you might be having. Those are the main ways where we think about decreasing the load. Other things, if you have a chronic cough or lung issues where you're always coughing very heavily, controlling that can really help decrease leakage. And then we think about, okay, how do we strengthen, what you have already, strengthen that support. So that's like physical therapy. Again, seeing a pelvic floor physical therapist can be very helpful. Also, there's something called a pessary. It's something that you come into the office and you get fit for. It's just a rubber device that fits in the vagina and has a little knob underneath that sort of presses against the bladder neck when you cough, laugh, sneeze, exercise, etc. So this can be a great option for women who, might just have leakage only when I do Pilates or only when I run marathons. And they can just want to manage it for that time. They don't want to have a full surgery for this. That can be very helpful. And then, of course, there are a lot of surgical options. The gold standard procedure is the tension-free midurethral sling. You see that as the second option there. It's very, very effective. Of course, you have to be the right candidate for it, but when you are, it works very well. There are also injectable bulking agents that work also quite well for this condition. And there are some surgical options that are less commonly used now just because we have these other minimally invasive options, but sometimes we do need to use those. So I do have to do those occasionally, and they have fancy names, but at the end of the day, they're all sort of geared at improving that support underneath the bladder neck. So we've talked about some of the minimally invasive treatment options, but just to go into more depth, the injectable bulking agents, it's a very quick procedure. You have kind of twilight sleep. We put a camera inside of the bladder, and right at the bladder neck, we inject in a few different areas this bulking agent that helps kind of plump up the inside of the bladder neck. This works really well for people who have that lead pipe urethra that I was talking about, or that intrinsic sphincter deficiency, or ISD. It is an outpatient procedure. It's very quick. It does typically need to be repeated because that bulking agent can dissolve over time. It's very minimally invasive, so it might be a better option for people who are a little bit sicker and maybe can't undergo a big surgery, but it's a wonderfully viable option. Then I talked about this gold standard of a mesh sling or a mid-urethral sling. They've been used for a very long time. I think they get confused with some of the vaginal mesh that we see on TV all the time. Everybody's getting sued and all these lawsuits. It's very different from this. That was vaginal mesh placed for prolapse. This is mid-urethral sling for incontinence. So different type of procedure for a different indication. Again, it's been FDA approved for over 20 years, and it's a procedure that takes about 20 minutes and it's typically around 90% successful. So again, it's a very wonderful option for our patients. This just goes into it a little bit more. The sling, it's like a tiny piece of mesh I place through a 1 centimeter incision inside of the vagina. There are different lengths of slings, different ways to do this, but I typically do what's called a retropubic sling. It's this picture is what that type of sling is. So you have 2 very small incisions right where the pubic hair is. Those go away eventually. And then, like I said, a 1 centimeter incision in the vagina. Healing time is about 6 weeks. People can typically return to work in a couple weeks, but you just can't lift heavy things during that 6-week healing time. But over time, you really expect to not have any more leakage. That's the expectation with this procedure. And as I said, for mixed incontinence, it usually involves treatments for both things. So for example, if you had some leakage with cough, laugh, sneeze, but the most bothersome thing was urge incontinence, we usually will treat the urge incontinence first. And that may either be with just lifestyle changes, medications, exercises, and then maybe some minimally invasive treatments. And then we see how the stress incontinence responds and then treat that accordingly. So what can you do as a patient? There are some resources where you can learn about urinary incontinence. I think the most helpful thing is to really bring this up with your doctor and get a specialty referral to a urogynecologist who can treat you for these things and counsel you even more. There's also ways to find these specialists if your primary care physician isn't aware of who they are or where they are, which can happen. There's a website, www.chooseyou.com, where you can help find a physician that specializes in this. So we always love to talk about some patient testimonials, but this is Renee. She noticed incontinence after her 4th baby in her 30s, and then basically just modified all her activities because of this. Instead of participating in sports, I became the photographer, because jumping, running, squatting, anything like that would be worse as far as the incontinence goes. So that's just not something that you have to do. The point of my job is to fix these things so you can get back to regular life and you don't have to be, sitting at home, or you don't have to be the photographer because you're afraid you're going to leak. I just wanted to say thank you, everybody, for tuning in. So I think we're good. Katie, thank you so much, everybody, for listening to this chat.
Thank you so much for your time. That concludes today's webinar. Have a great day.